Assalamu alaikum. Welcome to today's cataract surgery insight into a deep set eye with conjunctival chemosis. I'm Dr. Abdur Rahman Mohammad going to perform this surgery. You can see the chemosis in the left hand side, more prominent in the upper left hand side. I've decided to perform the surgery without draining the conjunctival chemosis. I don't want to further traumatize the conjunctiva. Since the surgical field is not obscured, I've decided to continue with the surgery. Now I have decided to make the continuous curvilinear capsulorhexis with a bent cystitome. A bubble came. Take out the bubble with OVD. Now commence with the creation of the continuous curvilinear capsulorhexis of 5 mm. Note that the pupil dilation is eccentric, but my capsulorhexis is spot on in the center. It is a centered continuous curvilinear capsulorhexis. This centered continuous curvilinear capsulorhexis will help in keeping the IOL in a centralized position in the bag. Here I'm performing hydrodissection, and this hydrodissection will enable me with easy rotation of the nucleus. I have decided to rotate the nucleus with the gel cannula. Now perform a direct vertical chop and chop the nucleus into 2 heminucleus. Now perform multiple vertical chop and sub-chop this 2 heminucleus into multiple pieces. Now all the pieces are chopped in the PC bag. Now in quadrant mode, emulsify the chopped pieces in a single-handed phaco technique. You don't need the second instrument to rotate the nucleus. You can easily rotate the nucleus with the tip of the phaco needle, as shown in the video. Remove the last few pieces of the nucleus and the epinucleus in the epi mode of the phaco machine. Remove the cortex with the help of the bimanual IA handpiece. The irrigation handpiece was not fitting through the left side port, so I have decided to enlarge the left hand side port. Now this enlarged side port was able to fit the bimanual IA handpiece easily. While removing the cortex, always note that you are holding the cortex and not the anterior capsule or the posterior capsule, because if you hold the anterior capsule and pull it, you can cause iatrogenic zonular dehiscence, and if you hold of the posterior capsule, you can cause PCT. To avoid this, always remember that in the periphery, you just use low vacuum to hold the cortex. While stripping, you should increase the vacuum. While aspirating in the central safe zone, you should give maximum vacuum to aspirate out the cortex. Always remember to strip the cortex tangentially and not radially, because radial stripping of the cortex can cause zonular stress and may lead to zonular dehiscence. Now load the IOL in the cartridge. Now implant the IOL in the PC bag and dial the IOL with the haptic into the PC bag. Now perform stromal hydration of the main port. Now remove the OVD with the bimanual eye handpiece. Now perform stromal hydration of the side ports and the main port. Now inject intracameral antibiotic and subconjunctival dexamethasone. Thank you, my dear friends. Hope this surgical video was helpful in developing your surgical skills.